Malnutrition in Older Adults by Alexandra Hardy. In 2015, the number of Americans aged 65 or older was 47.8 million, a 30% increase since 2005. The CDC estimates that by 2050, 1 in 5 Americans will be 65 or older, and the UN anticipates that the number of adults who are 60 and older will double worldwide to nearly 2.1 billion. Chronic health conditions such as cardiovascular disease, hypertension, arthritis, and type 2 diabetes are more prevalent among older adults and can affect nutritional needs, dietary choices, and food intake. The digestive and metabolic changes that occur in advanced age, combined with long-term medication use to combat chronic conditions, may increase the potential for drug-nutrient interactions. Malnutrition is the state of being poorly nourished. It may be caused by an excess of nutrients, which is classified as overnutrition, or the lack of one or more nutrients, which is undernutrition. For the purpose of this presentation, however, malnutrition will refer to the state of undernutrition. Undernutrition can consist of low muscle mass and be rooted in low dietary intake, such as starvation or inability to eat, reduced nutrient bioavailability caused by diarrhea or vomiting, or high nutrient requirements in the case of inflammatory diseases such as cancer or organ failure. Malnutrition is reported in up to 50% of older adults. A high proportion of older adults are at risk of malnutrition. It's estimated that 27% in the community are outpatients and 50% in all other healthcare settings are at risk. The chart shows the following malnourishment estimates according to the setting of care. Communities 3%, outpatients 6%, home care services 9%, nursing home 17.5%, hospitals 22%, long-term care 29%, as well as rehabilitation subacute care at 29%. Older adults are characterized by a decline of muscle mass, not only due to aging and poor physical activity, but also to poor adaptation to nutritional deficits. Since low muscle mass is now included as one important criteria to the new global definition of malnutrition, older adults are at high risk. Adverse effects of malnutrition are also more detrimental to older adults. These include a weak immune system, which increases the risk of infection, poor wound healing, muscle weakness and decreased bone mass, which can lead to falls and fractures, a higher risk of hospitalization, and an increased risk of death. Physiological issues. Age-related changes include changes in taste, smell, and appetite generally declining, making it more difficult to enjoy eating food and keeping regular eating habits. Illness. Disease-related inflammation and illness can contribute to declines in appetite and changes in how the body processes nutrients. Impaired ability to eat. Difficulty chewing or swallowing, poor dental health, or limited ability in handling tableware can contribute to malnutrition. Dementia. Behavioral or memory problems from Alzheimer's disease or related dementia can result in forgetting to eat, not buying groceries, or irregular food habits. Medications. Some medications can affect appetite or the ability to absorb the nutrients. Restricted diets. Dietary restrictions for managing medical conditions, such as limits on salt, fat, or sugar, might also contribute to inadequate eating. And finally, depression. Grief, lack of mobility, or other factors may contribute to depression, causing loss for appetite. Social issues. Lifelong food experiences such as food preferences or aversions that have been developed throughout the lifetime. Major life changes like retiring and transitioning to a less active lifestyle or moving to a more manageable home or assisted living facility. Bereavement, having to cope with the loss of a life partner or a loved one. Reduced social engagement. Older adults who eat alone might not enjoy eating as often and lose interest in cooking and eating. Limited income. Older adults may have trouble affording groceries, especially when they're taking expensive medication. and limited access. Adults with limited mobility may have limited access to food or the right types of food. Interventions. A food service approach to enhance energy intake of elderly subacute patients, a pilot study to assess impact on patient outcomes and cost. Objective. To evaluate a food service nutrition intervention on a range of participant outcomes and estimate its cost. The methods were the intervention was a modified hospital menu developed by substituting standard items with high energy options. The standard menu was used as a control and all participants received usual multidisciplinary care. Outcomes were change in weight and hand grip strength between admission and day 14, and energy and protein intake and patient satisfaction with food service at day 14. The additional cost of the intervention was also estimated. The results. The median age for the participants was 83 years, and the length of stay was 19 days. 38.5% were malnourished at admission. There was no difference in the mean hand grip strength change or weight change between the intervention and control groups. The intervention group had significantly higher mean intake, energy, and protein. Both groups are satisfied with the food service. The additional cost was €14.15 per participant per day. Conclusion. The intervention improved intake and may be a useful strategy to address malnutrition. Further consideration of clinical and cost applications is required in a full power study. The efficacy of a nutrition education intervention to prevent risk of malnutrition for dependent elderly patients receiving home care. A randomized controlled trial. The objective was to assess the effect of a nutrition education intervention included in the home care program for caregivers to prevent the increasing risk of malnutrition. Methods used. The nurses conducted initial education intervention sessions for caregivers and then monitored at home every month for 6 months. The group education session aimed at caregivers was 1 hour, standardized, conducted by a nurse and a small group of 15 caregivers. The nurses gave general information about foods, micro and macronutrients, and showed foods rich in nutritional content. They explained how to design a healthy diet, focusing on macronutrient distribution and food choices. They gave advice on dietary adaptation to address the most common nutritional problems in the group. They also gave recommendations on basic cooking techniques. Results. 173 individuals participated after exclusions. The mean age was 87.8, plus or minus 8.9 years, and 68.2% were women. The intervention improved the mini nutritional assessment test score of the participants in the intervention group. The egg consumption, protein intake, polyunsaturated fat intake, folate, and vitamin E showed significant group time interaction. Conclusion. A nutrition education intervention for caregivers halted the tendency of nutritional decline and reduced the risk of malnutrition of older dependent patients. Nutritional guidance. Nutrient-rich foods. Plan meals with nutrient-rich foods that include a variety of fresh fruits, vegetables, whole grains, lean proteins, and meats. Herbs and spices. Use herbs and spices to add flavor to meals to improve interest in eating. Healthy snacks. Plan nutrient-rich snacks to add energy intake between meals. Nutritional supplements. Use supplementation nutrition drinks to help with calorie intake. Add egg whites or whey protein powder to meals to increase protein without adding saturated fat. Protein intake in older persons should be at least 1 gram protein per kilogram body weight a day. The amount should be individually adjusted with regard to nutritional status, physical activity, disease status, and tolerance. Guiding value for energy intake in old persons is 30 kcal per kilogram body weight and day. This value should be individually adjusted with regard to nutritional status, physical activity, disease status, and tolerance as well. Effectivity. How and why are these interventions effective? Nutrition interventions for older people cover a broad range of different measures which all may contribute to and support adequate intake and go far beyond just providing adequate amounts of energy or nutrition. As with many geriatric syndromes, the identification and management of multiple causes constitutes the basis of appropriate nutritional care. When the physiological and social issues facing this at-risk population are taken into account, nutrition education can be an effective tool in combating malnutrition. Delivery is important when trying to get populations to participate in effective programs. These interventions showed effective delivery, such as creation of programs that patients participated in and benefited from but did not have to actively be involved in. They adjusted the hospital menu, increasing the energy and protein intake without the patient having to participate. The food service was still satisfactory and the patient was not inconvenienced. The nutrition education for caregivers and support system of a patient. Educational intervention sessions were for the caregivers. They supplied the caregivers with ways to design a healthy diet and dietary adaptations for common nutritional problems. Conclusion. In both of the studies, the at-risk population, older adults, benefited from some form of nutrition intervention. The first intervention was adjusting the menu, while the other focused specifically on nutrition education given to the patient's support system. Overall, there is a lack of research on this topic. There's a wide range of unresolved issues regarding the management of malnutrition and overall interventions. Further research is needed to include a nutrition education intervention as a standard part of home care. And high-quality research is necessary to develop effective strategies for prevention and treatment of malnutrition.